Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As a reminder, we offer these 30-minute briefings regularly on Fridays. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Jennifer Nuzzo, who's a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update about trends we're seeing in the COVID-19 data. Then we'll hear from Dr. Bill Moss, who is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. But before we begin, I want to say that today marks a somewhat sad occasion for us at the CRC, but an exciting one for Jennifer. After serving as the CRC's epidemiology lead for most of the last 2 years, next month, Jennifer will begin a new opportunity at Brown University. I know that I speak for everyone at the Coronavirus Resource Center when I say it has been an honor to have worked and laughed and cried with Jennifer throughout these difficult times. And we are so grateful for all the time and expertise that Jennifer has invested. Her efforts put the complicated yet critical subject of COVID-19 testing into national and global public awareness in a way that empowered citizens and policymakers. She has given all of us a greater understanding of how pandemics spread and how testing can help combat infectious diseases. Jennifer has been a critical player here at the CRC as we built an independent, reliable, and trusted pandemic resource. We will miss her contributions, but what we will miss most of all is Jennifer herself. Her level-headed insights during these briefings, in media appearances, on social media, with government agencies, and so many others. Some of you know that while Jennifer is both my colleague and my friend, we have not yet met in person, but we will remedy that soon. And now, on to the business at hand in today's briefing. Jennifer, can I turn to you first?
Yes, and thank you so much for that. It's been an enormous privilege to work with the CRC team. I'm really proud of all the work we've done and the interactions that we've had and commitment to education and having a sort of data-driven approach to understanding the pandemic and what to do about it. It's probably something that will not be matched in my career, but careers are long, and I hope the events of the world don't necessitate such an endeavor at the scale that we were able to launch this. I hope the world settles down in the future. The pandemic's not over, even though I'm going to be moving on to a new opportunity. Things do look quite different here in the United States. I like the trends that we're seeing nationwide. Case numbers continue to decline this week, down 30% from the prior week. That's very much welcome. We are also really starting to see now a decline in the deaths being reported, and that is very much welcome because the deaths that we have seen throughout this pandemic, while on a percentage basis of the cases generally lower, we've seen really extraordinarily high numbers of deaths in this Omicron wave. Is absolutely critical, and I'm glad to say that the trends are ticking in the right direction. In fact, this week we saw was the first time that we saw a death count below 10,000, which is the first time since really this Omicron wave started. So encouraging news on that front. I will have to say, going forward, I think the numbers that we're going to be looking at are going to shift quite a bit. With a decline in cases, with a variant that is causing a different level of disease in the community, seeing a smaller percentage of people who are infected going to the hospital, it's probably clear that the case numbers are increasingly not reflecting what's going on in terms of infections. We also know that people are increasingly relying on home tests, which are not captured in the official case reporting statistics. And so I think going forward, we're going to have to, look at multiple data sources to try to get a sense of what's going on. It's going to be harder for sure. I would say that the testing numbers and the case numbers are probably going to be increasingly less reliable given these changes in the pandemic landscape. So that is a challenge for sure. The fact that I see consistent trends in multiple data sets gives me a good sense that these trends are real, even if the numbers being reported may not reflect reality as even more so than they've always been. We've always known that cases have been underreported because not everybody who's infected gets a test. But going forward, I think we have to just interpret numbers with an increasing amount of caution given these trends. I think the story right now is looking worldwide and the trends that we're seeing worldwide. And one of the biggest developments for me has been in recent weeks seeing a number of countries starting to outrank the United States on our map, where on the left-hand side of the map, we list countries' case reports over the last month, and based on that number, they get ordered appropriately. The United States has been at the top of that list for most of my time here at the CRC, but in recent weeks, we've started to see now other countries rise above the United States in that ranking. Now the United States is outranked by Russia, Germany, Brazil, Vietnam, and South Korea. Really extraordinarily to see that we have slipped down quite a bit. I think it represents good progress, but it also represents the fact that many countries were later in seeing their Omicron wave and are now, really in the midst of it, whereas things are on the descent here in the United States. That list is also interesting to me because on it are two places that have been really celebrated in their abilities to respond to COVID. Vietnam and South Korea have both been quite successful at keeping their case numbers low, and when there are surges of cases, being able to bring them down quite quickly. I think the fact that they are now seeing a sort of rapid ascent in their case numbers, the rapid increase in their case numbers really speaks to the challenges that Omicron has posed, where it's a highly transmissible virus, and because of that, it has really sort of run circles around efforts to try to slow it through traditional public health measures. So I think that really should give us some humility in terms of this virus and its abilities to impact societies. I expect that these countries will see, like the United States, a descent rather quickly, but whether or not the death tolls will rise in the same lagged way that we expect is really going to depend on the level of vaccination coverage. And much attention has been given to Hong Kong as of late, where they also have been in a big Omicron surge, but because of poor vaccination coverage, low vaccination coverage of their elderly population, are now seeing a real stress on their health systems and a large increase in deaths, nothing that they've seen earlier in the pandemic. So it really just speaks to the fact that this pandemic, while abating, is very much not over. Of course, we all have to remain vigilant for the possibility of a new variant that arises that could cause us to have to change the game yet again. And I have to continue to stress, and I'm sure Bill will stress this in his remarks, the importance of making sure that everyone who's eligible gets vaccinated so that we can prevent the worst effects of this virus. That remains our fundamental goal, and I hope the world can remain laser focused on making sure that happens, because that will ultimately determine if we have serious illness or lose lives to this virus, or if it's something that we can live with.
Thanks, Jennifer. And I should say that I do see that several of you are sending in good wishes and congratulations for you, Jennifer. And we'll be sure to share all of that with Jennifer after the briefing. So, Bill, I'm going to turn to you now. We've seen questions rising in the last few weeks about vaccine durability and just generally what the future might hold. Can you give a sense of what we should keep in mind as we head into the spring?
Yes, thank you, Lainie. And before I start, I want to express my deepest gratitude to Jennifer for all she's done for CRC and the Bloomberg School of Public Health and the global community are remarkable insights and advice on how we respond to this pandemic. So Jennifer, I'm going to miss you, but I know you'll continue to make enormous contributions to public health here in the United States and globally. So Lainie, I'd like to address three things. First, actually, as Jennifer talked about, really vaccinating the unvaccinated as we head into spring and the months ahead of us. I'll talk a little bit about vaccinating young children, who are obviously a subset of the unvaccinated, and then some reflections on booster doses. So here in the United States, about 2/3 of those eligible are fully vaccinated, or of the population, about 260 million people. And so that leaves about a third of the population unvaccinated. Now, not all of those individuals are completely susceptible, as obviously many of them have been infected with SARS-CoV-2. I see analogies with what we've been dealing with for many, many years in the global childhood vaccination landscape. And so with global childhood vaccines like a measles vaccine, we kind of hit a plateau at about 85%. And the real focus globally now in childhood immunizations is how to reach those 15% of children who are unvaccinated. And we have a similar, challenge with COVID-19 vaccines here in the United States. That plateau is lower, at about 2/3 who are fully vaccinated, or 75% maybe who are received one dose. And this really requires local understandings and local strategies to try to move that needle. It often comes down to kind of two broad things: access to vaccines, which can be distance or time or cost, and demand. Where people often kind of underestimate the risk of the disease or overestimate the risk of the vaccine, and that's fueled by misinformation. But we know certainly some of the basic demographic characteristics of those who are unvaccinated or undervaccinated here in the United States against COVID-19. Age is a big one. And we've spoken about this before, Lainie. If you look at the 65 to 74-year-old age group, 95% have received one dose, at least one dose, 91% fully vaccinated. Really high coverage in older adults, and obviously they're the most vulnerable to severe COVID. But when you go down to the 5 to 11-year-old age group, only about a third have received a single dose, and maybe a quarter, are fully vaccinated. So quite low vaccine coverage among children, and I'll come back to that. One of the real bright spots, I think, is the kind of the closing of the gap across different races and ethnicities here in the United States. Asian Americans, much higher vaccine coverage, up in the mid 90%. But if we look across Black Americans, Hispanic, Latino Americans, white Americans, very similar coverage with at least one dose, and those fully vaccinated. So over time, that kind of gap in those demographic characteristics have changed. Now, we also see great heterogeneity across geographies and with political affiliations that kind of overlaid on that. Recently, the CDC published a study showing much lower COVID-19 vaccine coverage in rural parts of the United States. Just overall, for those at least 5 years of age, only 59% in rural areas compared to 75% in urban counties. So we have much more to do in rural counties of the United States in getting people vaccinated. And just to bring back an analogy to the global situation, really exciting, Pakistan announced that in Sindh province, they're going to train 13,000 women to do door-to-door vaccination for COVID-19. And this is really drawing on experiences with mass vaccination campaigns particularly for polio, where these door-to-door vaccination campaigns are done. And that's one way to try to close this coverage gap. Now, we've talked before, Lainie, about vaccines for young children under 5 years of age. We've talked before about the delays in the approval process, particularly for the Pfizer BioNTech vaccine. And I just want to talk about that a little bit. This is delayed because, as we've said, the results, particularly in that 2-year to 5-year age group, were lower than expected. And I just want to highlight why this is particularly challenging. And it's challenging because children are not just young adults, so things have to be adjusted. And there are a number of things that are adjusted. Some of these are related to vaccination of children, some of them more general, but particularly the dosage. What is the appropriate dosage of the vaccine that induces protection that's efficacious and immunogenic without more what we call reactogenicity, or those side effects, fever, soreness in the arm. And getting that right can take some time. And I think that's what we're seeing here. The dosage that Pfizer BioNTech tried, that 3 micrograms compared to 30 micrograms in adults, probably was not high enough to induce a strong immune response, but they were trying to balance that trade-off between immunogenicity and reactogenicity. What they've done is added a 3rd dose rather than increase the dosage. And so we're still hopeful that we're going to see results of that clinical trial in April, and hopefully have recommendations and authorization of the COVID-19 vaccine for children 6 months to 5 years of age. But again, I'm very concerned about the coverage. And as Jennifer said, with cases going down, hospitalizations and deaths going down, that demand for vaccine is going to be less. And we heard this week that Florida's Surgeon General declared that healthy children will not be required to be immunized in Florida, going against the CDC recommendations. So I think going forward into spring, we're going to see more debate about vaccine requirements for young children and school-age children. Some states will require school children to be immunized, particularly for the fall term. But this is going to be a debate that's really going to play out in the coming months. But I think the demand, there was a recent Kaiser Family Foundation survey that suggested that only about 20%, 1 in 5 parents of children younger than 5 years of age, say they're going to get their child right away. So there's a portion of the population where the demand is great, but we'll have to see what that coverage is. I think it's going to be lower than what we've seen in the 5 to 11-year-old age group. And then lastly, Lainie, just to touch about, what are we going to see going forward with boosters? We did see recently, this past week, that the World Health, expert advisory group to the World Health Organization did support urgent and broad access to boosters. Earlier, the World Health Organization had thought or had not supported the use of booster doses in an effort to achieve vaccine coverage equity with 2 doses, 1 or 2 doses, depending on the vaccine. But Omicron really changed the calculus here because of its ability to evade immunity, particularly even in those who had received 2 doses of an mRNA vaccine. Now, some people are currently eligible here in the United States for a 4th dose, those who are moderately to severely immunocompromised. Israel has recommended a 4th dose in those older than 60 years of age. But what is it going to be for most of us, going forward with boosters? It's really going to come down to what's going to permit infection and disease, particularly severe disease in people. And that's 2 things: a new variant that can escape immunity, or significant waning immunity. What we've seen is that, and it's very important when we talk about waning immunity to consider what the outcome is. We've certainly seen, particularly with Omicron, that vaccine protection against infection wanes pretty quickly, in on the order of 4 to 6 months. But vaccine protection against severe disease has remained relatively high. Again, some decrease with Omicron, but still importantly high. So it's going to be this, whether or not we see the emergence of a new variant that has this immune escape. There's no doubt we're going to see new variants, but can they escape the immunity that prior infection and prior vaccination have conferred? And how much waning immunity that we see, particularly against hospitalizations and deaths. Last point, Lainie, and we've talked about this before, what are those booster doses going to look like? We are seeing some progress in the potential authorization or approval of a Novavax vaccine. That's a protein-based vaccine. The Sanofi GSK, there are multiple protein-based vaccines, and it could be that we see booster doses with the come fall, for example, with these protein-based vaccines. And I'll stop there, Lainie. Thank you.
Great. Thanks so much, Bill. I'm now going to turn to the questions that have been coming in. And Jennifer, I'm going to send this first question to you. So we've now seen every state drop its mask mandate or announce a plan to do so. We've seen updated CDC recommendations. Is it fair for people to be saying that the pandemic is over?
So I don't think anybody seriously is saying the pandemic is over. Maybe some people wish it were and is trying to will that into existence. But no, the pandemic's not over. But there is a difference between having a mandate and saying that masks are no longer necessary. And nobody has said the latter. I think what you're seeing is a bit of a refinement of the metrics being used to assess whether on an individual basis masks may be necessary. The CDC issued new guidance, and where they had previously relied on just two metrics, test positivity and case rate, they now have a bit more of a complex way to assess whether communities, whether the risk of spread in communities is such that they would recommend all people in those communities wear masks. I personally think the shift was necessary because, as I said in my remarks, the case and testing data are becoming increasingly reliable, and only using those, I just don't think reflect the new phase of the pandemic that we're in. I think it makes sense to look at other things, such as what percentage of the cases are going to the hospitals. Are hospitals overwhelmed? Because we know that those are important dimensions for whether this is a serious illness where we are quite worried, or if it's more like other respiratory pathogens that we live with. That said, you can still benefit from wearing a mask if you so choose. And, people who are at increased risk may want to continue to do that regardless of what the current list of spread is. I will just say, I think it's important for people to recognize that this virus isn't going away. And so when we're talking about whether or not masks are necessary, the question is, what are the conditions that would make people feel comfortable not wearing masks? We set those levels differently as individuals. I, as a fully vaccinated person without any underlying health conditions in a family that doesn't have any health conditions, feel quite protected as a fully vaccinated person. I still wear the masks when I go into indoor crowded spaces, in part out of etiquette for not knowing the status and comfort of people who are around me. But I think no government guideline is ever going to make not important our need to take care of each other as individuals, take care of our community members, and to have that level of concern for others.
Thanks, Jennifer. Good to know that you're not bringing unfettered optimism to your final briefing. I'm glad that you're still measured. Okay, Bill, question for you. For someone who got their booster 6 months ago, so they are more than 6 months out, what does the data tell us? Should they be thinking about another booster?
Yeah, so currently for otherwise healthy individuals, the CDC does not recommend an additional booster. It is true that we do see waning antibody levels 4 to 6 months after that booster dose, but the current evidence suggests that booster dose continues to provide strong protection against severe disease. And it's quite, and it has to do with the two different arms of our immune systems, our antibody response, and that's what really wanes. And when those levels get down, we are more susceptible to infection. But our cell-mediated immunity really persists, and that's really critical for protecting us against severe disease. So I would say for an otherwise healthy individual who's had their booster dose, I think it's safe, and according to the guidelines, that such a person would not require a booster dose at this time. Again, we'll have to see how this kind of plays out going forward. But it could be, for example, the scenario where come fall, and we anticipate a rise in SARS-CoV-2 transmission during the winter months, that there could be a booster dose offered at that time. We just don't know yet.
Right. Thanks, Bill. Jennifer, question for you. How do we find out whether new variants exist? What's behind that process?
Yeah, so basically we ultimately have to do a sequence of the virus. And in order for that to happen, someone first has to be diagnosed. And then we have to make a decision about which clinical specimens we're going to send for sequencing. Now, depending on the variant, there may be an interim step where we possibly get a signal from the PCR tests, but that's not the same for all of the variants. What is ultimately going to determine, though, and I think it's an important issue to track going forward, particularly as people may be increasingly less likely to get tested and increasingly more likely to rely on home tests, is that the amount of physical specimens that will exist will decrease. And that is the first step that has to happen in order for us to then further characterize the virus in order to know if it's a variant. So I think increasingly it's going to be harder. And that's one of the areas that I have deep worry about. And then, of course, there's always the worry that not all places are doing the same level of searching to identify variants. Some countries are far more aggressive in sequencing a proportion of their cases in order to find variants. It's one of the reasons why South Africa is often first to report one, because it is looking harder than many other countries. That problem has existed, but I think it's going to be exacerbated by the fact that there is a shift in the testing landscape. There is also the other problem of not all places where sequencing is done are contributing to sequencing equally. So for instance, in the United States, the variant tracking that we do based on the amount of sequencing that's done may not represent all of the United States. It may be dominated by urban areas in the United States. And so it's always really difficult to kind of get a complete picture and to make sure that we are staying on top of it. And frankly, it's one area that I think we have to dedicate some efforts to fixing. I will remain steadfast in my belief that our failure to develop a national testing strategy has absolutely hindered us. This is one area in particular. We need to, even going forward, even as the case numbers are going down, figure out how we should use testing to maximize the amount of information we can get out of it and to make sure all the critical questions that we need to have answered are answered. I remain hopeful that one day someone will see the light and we will have a national testing strategy, but so far we don't.
Well, it is 12:30, and Jennifer, I think that is a fitting last note for your final briefing with us. So I would like to thank Jennifer Nuzzo and Bill Moss for joining me today. Give a big thank you to everyone who joined us, and especially those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we will continue to offer these 30-minute briefings regularly on Fridays. Next Friday, March 18th at noon, we'll host the next installment of our Pandemic Data Initiative Expert Forum with a focus on the future of data. Until then, thanks and stay safe.